All right. Thanks. So I believe my mandate today is to review some of the basic concepts and ideas around the full public health value of vaccination. So that's what I'm going to do. And people who know me, I only have a few themes, and I talk about them fairly frequently. So people who have seen this before, there's quite a few slides that you would have seen, but hopefully there's some new stuff. You can sleep through the slides you've seen before and hopefully wake up for the other ones. And I'm going to go through some of the concepts fairly quickly. I'd prefer to get to the question sessions, but this is fully available, so it'll be on the on the thumb drive that everybody gets at the end if you want to see any of the specific points in there. So first, I'm just going to go through a couple of ideas around how decision making is made, and I've been involved in this particular area with different groups for many years, and this is just the number of vaccine launches that Gavi had in 2013, and the timeline is at the bottom, and the size of the circle, the color of the circle is the vaccine, and the size of the circle is the number of people that actually got vaccinated. So the bigger countries are bigger circles than the littler countries. And just so you know, I'm not gaming the system, that's 2014, and that's 2015. They keep changing the exact way they design the figure, but you get the idea that it's pretty standard. Do you have a pointer, by the way? Yeah. That would be great. Excellent. Okay. So this was a paper, and I quote it because I like the quote because it supports my pre-existing biases, but disease burden has been consistently mentioned by policymakers in countries to be the #1 factor in setting priorities for vaccines. And I mention this because a lot of this talk is around how to measure burden accurately. There's many other issues, but I focus on burden because that's the core foundation that everybody says is the basis of the decision-making process. And so you can see this was a global look at immunization technical advisory groups. And this is a measure of burden, disease severity. This is disease burden in other countries. And this is the disease burden in the home country. So the NITAGs are all saying they look at disease burden as a core factor for making decisions related to vaccines. This is SAGE. So SAGE says in making its recommendation, they take into consideration issues such as disease epidemiology and specifically disease burden. This is Gavi, and I'll just run through this. And so this is their vaccine investment strategy. This has changed. This was before the current investment case is being rolled out. But you can see that the vaccine investment strategy really focused very heavily on the burden and the vaccine's ability to impact that burden, child mortality, overall mortality, and overall morbidity. This is a statement from the Global Health Group at the Gates Foundation, which is our starting point in deciding where to focus has been the disease burden in developing countries. So again, all the major groups that are in the countries where I work, disease burden is the key. And so here are some decision-making issues that I just sort of put together in terms of what are the key issues that I think will be discussed over the next couple of days. So in low-income countries, many countries have introduced vaccines that you saw in the first few slides. The financing is largely dependent on Gavi, and countries initially have relatively small copays. I'm hoping most people know how the Gavi system works. Transition to full country financing is going to place strains on country health and national immunization program budgets, and in fact has already done this. And many countries, even in the middle income groups, are trying to decide which vaccines they can afford and over what time period. Middle income countries already assume the full cost of vaccines, and some of these countries only have marginally greater budgets than the low-income countries because at that line at which Gavi funds, I mean, that's a hard line. There's no concession for being just a little bit above that line. There's anti-vaccine groups that are more and more active, and I'll go into that a little bit later. There's complacency in places where the disease hasn't been seen in years, and so people don't understand why they even need to use the vaccines anymore. So for all these reasons, I think valuing the vaccines appropriately is going to be critical to sustaining programs or even getting vaccines introduced to begin with. And then traditional metrics like vaccine efficacy or effectiveness and safety just are not enough. And so this is something I've presented a lot. So this is the per protocol analysis of vaccine efficacy. And this is, these vaccines were all basically considered a success. So this was Hib vaccine, rotavirus vaccine in South Africa, pneumococcal vaccine, and rotavirus vaccine in Vietnam. And then these vaccines, when they came out or when the papers were published, were more or less considered equivocal or even failures. And so that was the rotavirus vaccine in Malawi, rotavirus vaccine in Bangladesh, which is over here, cholera in Calcutta, malaria vaccine in older children or older infants, and then the younger infants. And in fact, I remember when this data first came out, there was just a pall over the room. I mean, GSK was depressed, and they wondered if their vaccine was dead. And I look at this and think, well, this is this incredibly bad disease, and you can prevent 50% of it with one single thing that you can do. So I just thought it was a no-brainer. I mean, there's other issues with the vaccine, but in terms of the efficacy, I really didn't understand the initial response to it. Okay, so this is a quote from T.S. Eliot: "Between the idea and the reality falls the shadow." And so one of the things that I like to emphasize is the importance of not just focusing on ideologically confirmed outcomes. And these are all the reasons why I think it's really it's insufficient to look only at an ideologically confirmed outcome such as Hib or invasive pneumococcal disease or rotavirus confirmed acute gastroenteritis. So there's lack of referral, lack of transportation, economic barriers, there's all these investigator issues, lots of things can happen at the laboratory. There's a few other issues that I don't think are really is well appreciated, but may in fact be the most important issues. So there's imperfect entry criteria, case definitions. So people may not even get into a study to be evaluated. The organism might be part of a causal chain and not be present. So that's the idea behind maybe influenza causes a lot of bacterial pneumonia, but by the time they come to the hospital, the influenza's gone and all you find is the bacterial etiology. The reverse might be true, might be present and not part of the causal chain. This is actually true even if you're doing a case control study and you show that there's an association in that case control design. So that isn't assurance that the etiology you found is part of the causal chain. And then this, I think, is really the most interesting thing, which I think we really have an imperfect understanding of the outcomes associated with any particular type of infection. And there may be all sorts of causal chains that we don't understand. So if you prevent one infection, it may have this cascading effect on all sorts of different outcomes. And I just put up the example of how measles actually precipitates malnutrition. So if you prevent the measles, you prevent the malnutrition. But if you don't measure malnutrition in your study, you'll never be able to assess that burden. And then just lastly, all of that's going to vary by age group, risk groups, and often this will impact those most at risk. And I gave this presentation most recently for typhoid, so that's why it says for typhoid. And here are some definitions that I'll just go through real quickly. So the first is a vaccine preventable disease incidence. This is also the exact same thing as the vaccine attributable risk. This is not some new mathematics. This is a well-known concept in epidemiology. I just gave it a different title. These formulas are the formulas if there's no indirect effects of the vaccine, and I'll go through that in a second. But basically, it's the incidence in the unvaccinated minus the incidence in the vaccinated, and that's mathematically equivalent, if you just rearrange things, to the incidence in the vaccinated times the vaccine efficacy or effectiveness. And basically, it shows that it's taking this value, which is traditionally what's used for licensure, and incorporating the idea of the background incidence of the disease. And in layman's terms, it's the number of cases averted per unit of vaccinated people per year. And the number needed to vaccinate is another concept that's been used more and more lately, and that's the number of people that must be vaccinated to prevent one outcome. It's not a rate, so it incorporates the length of the trial or the duration of immunity if it's outside of a trial setting. So if the vaccine preventable disease incidence is reported per 100,000 vaccinated persons, this just equals 100,000 divided by that value divided by the length of the study. It's sort of like an inverse of the preventable disease incidence, but I'll show you plenty of examples of this. And this, I think, is the last sort of conceptual issue. Danny Feiken led a paper that was published in The Lancet, and this is looking at a hypothetical example of pneumonia. And so this would be the unvaccinated population. This is the vaccinated population. The purple is the target etiology. And then here are various ways you could measure it. And so this is etiologically confirmed. So most of those, I mean, all of them are the target etiology, right? That's by definition. And you have a very high vaccine effectiveness, which is the ratio of this to both of these together. But you can see as you go down, the proportion gets smaller and smaller, but the total size of the pie gets bigger. So even though you can just visually see that the efficacy or effectiveness is going to go down as you go down here, the actual amount of disease that you prevent goes up. And so I'll show you some examples of how that works. And this is the first one, and these are all real examples. So this is the Gambia PCV trial. This is a trial that I worked on in Indonesia for Hib. This was Danny Feiken with Kenya in rotavirus. This was Felicity Cutts who led that. Anyway, the syndrome that I'm focusing on here is radiologic pneumonia for the Gambia trial. And you can see the vaccine efficacy here was 70%. The vaccine preventable disease incidence against etiologically confirmed disease, in this case invasive pneumococcal disease, was 1.4, and this is per 1,000 child years of observation. So you would need to vaccinate 357 kids to prevent one case of invasive pneumococcal disease. But if you go to the clinical outcome, which is just radiologically confirmed pneumonia, the efficacy is now 37%, so it's half as much. So if you came to a minister and said, I have a vaccine that's 37% effective, they'd likely say, okay, well, we're done here. But if you look at the preventable disease incidence, it's 10 times higher, and you only have to vaccinate 38 kids instead of 357 to prevent one episode of disease. So that just right away shows you that the efficacy by itself is essentially uninterpretable from a public health viewpoint. I mean, I don't even understand how a minister could make any sense of that. I mean, the first question should be, well, what's my background rate of disease? How many kids do I need to vaccinate to prevent one case of that? And in Indonesia, the same thing was true with hospitalized meningitis. Against Hib meningitis, it was 86% effective, which is what everyone else has seen. We found low rates of Hib meningitis that were documented just like every other study in Asia had found at that time. Fourfold lower effectiveness if you looked at just the clinical outcome of hospitalized meningitis. But it was, again, 10 times higher preventable disease incidence, and the NNV was 1/10 as much. And then lastly, Kenya was rotavirus, and this was acute gastroenteritis confirmed in the hospital versus all causes in the community. And again, it's about a third here, and this is 6-fold higher here. So it's the same thing across all of these studies. It's not just in developing countries. So when I talk about this, a lot of people think it's just a diagnostic issue. People aren't identifying the cases in these resource-poor settings because they don't have the appropriate laboratory or diagnostic capacity, which is why I like this study from Finland. So I would argue Finland is pretty good at diagnostics, and they're a well-advanced country. So this is confirmed inpatient acute gastroenteritis and confirmed as rotavirus. And this is all cause. Vaccine efficacy was 80% against confirmed rotavirus, 54% against all cause, but it was 3-fold higher here. So they're missing 2/3 of the gastroenteritis that they're preventing. Now, I can't even argue that they're missing 2/3 of the diagnosed cases. This may just be that rotavirus sets up something where you get other types of diarrhea, or that the rotavirus is gone by the time you come in and there's some element of chronic diarrhea. But whatever the issue is, you're missing a lot of the diarrhea that you can prevent if you just focus on the etiologically confirmed. And then this just shows what I had showed on that first slide, which is comparing South Africa to Malawi. So the effectiveness was lower in Malawi than South Africa, but you prevent a lot more disease, 50% more disease in Malawi than South Africa. And that's just because there's so much more disease in Malawi than there is in South Africa. And the exact same thing was seen in Vietnam versus Bangladesh. Higher efficacy in Vietnam than Bangladesh, 50% more disease prevented in Bangladesh than Vietnam. So even though the efficacy is lower, it's a better intervention. It costs less per child, per case of illness prevented in a child in the country with lower efficacy than in the country with higher efficacy. And then lastly, I think this is the last slide on this topic, is malaria. And so you can see I just divided into no booster and booster in the 5 to 17-month-old group, no booster and booster in the younger infant group. And this is malaria, and this is all-cause hospitalization. And you can see that even in these settings, which were specifically picked because they know how to do malaria diagnostics, they know how to do malaria care, get people with malaria in, you get 50 to 100% more prevention when you look at the non-specific outcome of all-cause hospitalization than when you focus just on malaria. Oh, there was one more. Okay, and this was something that I put together for dengue vaccine. And this shows some of the value of looking at preventable disease incidents. And this was to show ministries of health that they're already using vaccines that have about the same ability to prevent disease as dengue. So they've already accepted that Hib, pneumococcus, and rotavirus prevent enough disease to use in their settings. And so I just plotted out, well, what is, how much disease are you preventing? What's the vaccine preventable disease incidence? And how many children do you need to vaccinate to prevent one case of illness? And here's the efficacies, and these are all studies done in Latin America, by the way. And I didn't focus too much on this, but you can see that this compares pretty favorably to all these other vaccines. I mean, it prevents a massive amount of disease because dengue largely causes outpatient illness in Latin America. But even if you look at hospitalized cases, it's not so different than invasive pneumococcal disease, or Hib, ability to prevent all pneumonia hospitalizations. So when I haven't been there for all the presentations that have gone on with the ministries, and there are people here from Latin America who could speak to this more, but I've been told that that's a fairly powerful argument for ministers to see that type of argument. So this was the first slide that I put up, and then if you just reorganize that slide by vaccine preventable disease incidence, it all of a sudden looks very much different. So these are the exact same colors, but here's a study that was more or less considered a failure based on the vaccine efficacy, and it prevents the most disease of any of the vaccines that were analyzed in this analysis. And then it goes on down, and one of the ones that was considered quite successful is actually towards the end. So the next thing I wanted to talk about is, I think this will be discussed more later in the meeting, but just the idea of individual versus cluster randomization. And this is Ira Longini and Betts Halloran actually put this together originally. And this shows the schematic design for a cluster randomized trial. So this is the intervention cluster. This is the non-intervention or the control cluster. And you can see that some people will get vaccine in the intervention cluster and some people will not. Presumably nobody in the control cluster gets vaccine. And then there's these various measures that you get from this type of study. So one is the overall, this is the standard measure, which is comparing the attack rate here versus the attack rate in that overall group. And then you can also get the direct protection by comparing this group to this group, indirect by comparing this group to this group. And this is not used very much, but you could compare unvaccinated here to vaccinated here, and Ira and Betts called that the total. So here are some limitations I came up with just on my own. I'm sure there are other ones that other people could come up with, especially people that do more clinical trial stuff than me. But indirect effects, if you just do an individually randomized clinical trial, which is what most licensing trials focus on, because that's what regulatory agencies tend to want. And if you just focus on etiologically confirmed disease, there's a lot of limitations. The indirect effects can't be measured in the target age group. You can do indirect effects outside the target age group. There's usually insufficient power for rare outcomes such as mortality. There's usually insufficient duration for some outcomes, asthma and wheezing for RSV, neurologic sequelae for all of the conjugate vaccines. Individually randomized trials may be difficult to implement during outbreaks, and so outbreak-driven diseases for which there are currently vaccines are cholera, Ebola, and dengue, as well as others like yellow fever and Japanese encephalitis. Focus on etiologically defined disease, which may greatly underestimate all disease, so that's what I had shown before. And then the last thing, I'm going to just briefly go into this, but these values, which I consider the most useful public health values, can be really distorted in an individually randomized clinical trial. And here's what that looks like schematically. So let's say you are looking at Hib vaccine, and this is what it looks like pre-study. So you have an incidence of 100 per 100,000. So that's about what Hib meningitis incidence was before vaccine was used. And obviously it's the same in both groups because you haven't used vaccine yet. So let's say you have a direct efficacy of 80%. So you prevent 80 cases there, and that's what it looks like. And your preventable disease incidence in this case is also 80 because it's just 100 minus 20, right? So that's all fairly straightforward. But let's say you then take this and you reduce it by another 50% because you have indirect effects. So this goes from 20 to 10, so you prevented 50% of that. This goes from 100 to 50, 50%, you prevented 50% of that. So your measured vaccine effectiveness or efficacy remains 80%. So that's a stable value in this, whether you're doing an IRCT or a cluster randomized trial. But the preventable disease incidence is actually you're going from 100 to 10, which is 90, and then you're going from 100 to 50, which is 50 in your control group. So your overall ability to prevent vaccine is the sum of those two, which is 140. So instead of it being 80, it's 140, which is almost double. And this is also why the values I gave you before are for, even for a cluster randomized trial, you have to take into account the indirect effects. And I just graphed this out because I was interested to see how this played out at different levels of direct and indirect efficacy. And so on this side is, this axis is the direct vaccine effectiveness or efficacy. The different lines are the indirect values, and this is the fold difference between the measured and the actual burden of disease that you would prevent if you use that vaccine. And you can see as the direct efficacy goes down and the indirect goes up, which is the blue versus the yellow, you can get just massive differences in what you measure and what the actual preventable disease incidence is. So this is yet another reason, and I think a really major reason, if you really want a public health value, if you really want to be able to tell somebody how much disease they're going to prevent, why you need to do cluster randomized trials. So here are some other concerns. I will go through these things quickly. I'm not going to go through all these little points here. It's just to illustrate that these differ from really not an issue at all to a massive issue for that particular disease and vaccine. And so the first thing is severity, and I just mapped out all of these different vaccines. This is just my own opinion. I think people could have their own opinion as to whether I got this right or not, but it's just to go through some other issues. So this could be mortality, hospitalization, or outpatient disease. And so some diseases like dengue are really mainly outpatient disease. Other diseases like pneumococcal and Hib meningitis are really more mortality and hospitalization. And so when you're comparing one vaccine to another, if that's the metric, if that's the decision you're trying to make in a country, which one to introduce first, you need to take into account the severity of the disease, not just the disease burden. I think you need to take into account the sequelae. So those could be cognitive, mental retardation, developmental delay, language delay, learning disability, language delays. Mental health I threw in there. I think this is a big issue for HPV that doesn't really get incorporated into models and economic costing. So if you have a teenager who's 18 years old and they all of a sudden have genital warts, I mean, that's a massive issue for a teenager. Not to mention cervical cancer for a mother and then all the people around her who are relying on her and thinking that she's going to die, and she may very well die. There's sensory issues. Physical, cerebral palsy and seizures, stunting and growth effects are also concerns. There's the duration of immunity. So this I consider not the vaccine efficacy to be the major issue with malaria vaccine, and that is that it doesn't seem to last very long. Pneumococcal and HIV vaccines last pretty long with a booster, or maybe even if you just give a single dose at the right age. HPV seems to be in this same camp. Cholera and dengue seem to be moderately long based on existing data and may in fact be really long if people follow that out for years. And then rotavirus, obviously it doesn't really matter. You just have to have it last for a year or so. Age distribution. Most people in vaccines tend to be pediatricians or people that apparently don't like adults very much because the focus is always on this. And in fact, I was at a conference on pneumococcus and I was trying to argue that there's a lot of pneumococcus in older children and adults. And one of the comments from a pneumococcal expert was, why are we talking about this? This is a vaccine for kids. It was developed for kids. We should only be using it in kids. Let's stop discussing adults. But if an adult dies from pneumococcal illness, it may throw the entire household into poverty. So even though I'm a pediatrician and also don't really like adults that much, I still care about preventing their illness. And so, if you look at rotavirus, if you deliver rotavirus, even if the vaccine, even if the duration of immunity were 70 years, it wouldn't matter because all the disease and all the outcomes occur in the first year. But if you can give a lifelong vaccine that prevents pneumococcus across the entire lifespan, that's huge. Same things with dengue and malaria as well. I think you have to consider indirect or replacement effects, which is sort of a public health value measure of saying that the vaccine doesn't really last that long. So it's not that it doesn't last against the specific etiology that it targets, but from a public health perspective, it may not functionally last. So if you're trying to prevent pneumonia, you don't really care about whether it's vaccine serotype pneumonia. You just care about whether you have less pneumonia than you did before the vaccine. And so pneumococcus has both indirect effects, but also has replacement. I think it's a little less clear for the 13-valent, definitely was occurring for the 7-valent. Plenty of these don't have replacement yet, but if they get used long enough, they may. I think outbreaks in politics is another area that really doesn't get measured hardly at all. So vaccines can prevent all of these things. So massive outbreaks in cholera and dengue, disruption of health system, again with cholera and dengue. I think there's probably going to be some talks later about how the major outcomes from the Ebola epidemic may have been the disruption of the health system and the impact on other diseases and not on Ebola itself. So in order to measure the impact of an Ebola vaccine, you'd have to incorporate all of those. Whether the disease is politically sensitive, could a government potentially be overthrown because they failed to address adequately that disease? And there are definitely diseases in that category. And then impact on tourism. There's economics, so all of these issues have economic consequences, and it's not just society and the health systems, it's the communities with tourism and business development, it's household. And all of that needs to be incorporated into models. This is a paper that someone who works for us, Anais Colombini, basically pioneered, which was looking at the impact on the household of a disease. And this was in support of the meningitis vaccine project. And she basically showed that one case of meningitis, so here's the key point here, was 34% of the annual income in that population. So you think one case of meningitis, even if you're being charged at the hospital, couldn't possibly be that big a deal. But really one case can throw an entire household into poverty in these settings. This is what I talked about before. This was a paper we wrote up on the actual burden of pneumococcal disease in the meningitis belt. And basically here's what I was saying, which is that I think it's something like 60% of the disease, the pneumococcal meningitis, was occurring in people 5 to 59 years of age, as well as 60% of the deaths, even though the focus is on the under 5s. If all that's prevented through indirect effects, it's great, but if it's not, then that's a target group for using vaccine. And then the last slide on this topic is equity and ethics. And this is really a hard thing to cost out, and so it emphasizes that you can't just put it all into a computer box and have it spit out a number for you and say this is the better vaccine or this is a good intervention. So you can have occurrence of the disease be higher in disadvantaged than in advantaged countries. So for example, malaria or cholera basically are diseases of poor countries, but within those countries, it can be higher in the disadvantaged. Malaria, a lot of people in disadvantaged countries get malaria even if they're advantaged, so that's why I gave it only 2 pluses. You can have the severity be higher in the disadvantaged even if everybody gets infected. And then you can have the mortality be higher in the disadvantaged. And that's almost universally true except for diseases where mortality is just low anyway. Okay, so this is the last thing I'm going to talk about. So for people of a certain vintage, you might recognize this quote, but it's just the facts, ma'am. So that was Sgt Joe Friday from Dragnet during a simpler era, maybe, from 51 to 59. So this is from November, post-election USA. He says, "I'm sorry, Jeannie, your answer was incorrect, but Kevin shouted his incorrect answer over yours, so he gets the points on a game show called Facts Don't Matter." And so here are some quotes I just pulled off of the internet because I'm just fascinated by this, and it was a lot of this surrounds Facebook. But this was somebody who was a big supporter of Donald Trump and the news director of the Tea Party News Network, and she basically said, people that say facts are facts, well, they're not really facts. Everybody has a way. It's kind of like looking at ratings or looking at a glass of half full water. Everybody has a way of interpreting them to be the truth or not the truth. There's no such thing, unfortunately, anymore as facts. And then this, just as a data point, is really fascinating. In the final 3 months of the US presidential campaign, the top performing fake election news stories on Facebook generated more engagement than the top stories from the major news outlets, which were considered not to be fake. And then this I love, because then it's a meta level. Even the coverage of fake news is fake. So when confronted with this, the founder of Facebook, Mark Zuckerberg, said, "We do not want to be arbiters of truth ourselves." So some people thought that was punting, such as this fellow from the New York Times who said, "Truth," in response to this quote, "truth doesn't need arbiters, it needs defenders. Today's fake news is limited only by the imaginations of its inventors and the number of shares it can garner on Facebook or Twitter." So I bring all these things up because we can have all the data we want and be much more precise about what the true burden of illness is and how we can prevent that with vaccines. But unless we address these issues and that somebody can just stand up and say, "You're wrong and vaccines kill people," then we're not going to move the agenda forward. And I have one example, and I have quite a few of these that I could go through, but this is also a mea culpa. So it's not just Trump supporters or people on the far left that are guilty of adjusting the facts for their pre-existing biases. It's true of all of us. And this is an example with Hib vaccine and pneumonia. And so these are some talking points. And the basic talking point is that Hib vaccine prevents 20% of severe pneumonia. So the first quote was from the bulletin of the WHO, says pneumococcal and Hib conjugate vaccines reduce pneumonia by approximately 26% and 18% respectively in clinical trials. Another quote was from a group in India. They said Hib is estimated to cause over 20% of life-threatening childhood pneumonia. And then the Hib Initiative Hib Fact Sheet, so this was the authoritative group that supported the rollout of Hib vaccine, said in most pre-vaccine studies, Hib caused approximately 20% of severe pneumonia. So first of all, it's not even possible to know how much severe pneumonia is caused by Hib. There's only how much severe pneumonia you can prevent with Hib vaccine. But anyway, you can see all of those focus on the data point of 20%. So what does the data actually show? So this is the proportion of severe or hospitalized pneumonia with a lobar infiltrate or pleural effusion. And these are 4 different studies that were done. And basically about 20% of hospitalized pneumonia has that characteristic, that it has a radiologic infiltrate that's a consolidation, a lobar consolidation, or a pleural infiltrate. And then this is the vaccine efficacy or effectiveness against pneumonia with that finding and against severe or hospitalized pneumonia. And you can see, in fact, that it's 20%, not everywhere, but let's say most places, for this outcome. But I would put to you, there is not a minister anywhere in the world that cares whether that vaccine prevents that pneumonia. What they care about is this pneumonia, severe and hospitalized pneumonia, and that's what got conflated. But the real impact on that is actually about 5%. And I would argue it's even less than that because those studies are done in people 6 weeks to 2 years of age, and Hib is probably less likely in people under 6 weeks of age, and those aren't even getting measured in these studies. So the actual data points for me are that Hib vaccine reduces severe and hospitalized pneumonia by approximately 5%. And in some, but not all settings, this reduction occurs primarily for pneumonia with lobar consolidation, pleural effusion on chest x-ray, a category that constitutes about 20% of all severe or hospitalized pneumonias. And this is actually the conclusion that was produced in Stanley Plotkin's vaccine book on the Hib chapter. So here are some conclusions. Vaccines can and likely do have large effects beyond preventing etiology-confirmed disease in individuals. The effects are poorly captured, and hopefully we'll look at ways to do that better during the next few days. Here are some areas for improvement that I came up with. So additional outcome measures, different trial designs, inclusion of clinically defined outcomes, measurement and inclusion of societal benefits, including those that relate to economic gains. Many of these topics could be incorporated into licensing trials. They would just need to be discussed in advance with regulatory agencies. And then finally, good data are not good enough. I think the vaccine community must care about fully assessing a vaccine's value. It's interesting to me that I think even manufacturers, who you would think have the greatest incentive to fully value a vaccine, don't seem to really care about doing this. The vaccine community should accurately communicate this values, and we need to find solutions to overcoming misinformation and pre-existing biases. I have no answers to that issue, but somebody should come up with something who's smarter than me. And this is the last slide. In an increasingly complex world, sometimes old questions require new answers. All right, thanks.